So here's the tough part. I'm telling you to assess it as a clinician, but there really are no validated ways to assess someone's exposure, environmental pollution, and then to think about how to put that into risk assessment model. So it's a little bit more of a gestalt. We certainly have some surrogates that we can use to assess somebody's risk. So I like to use their zip code, which has now been incorporated into the prevent equations to sort of be a surrogate for socioeconomically disadvantaged areas, but can also be a surrogate for urban areas because certain areas, urban zip codes have higher levels of air pollution than suburban or rural zip codes would, for example. You look at their occupation and their housing situation. So you want to look and see, are they like a laborer who works outside all day long? That certainly would increase their risk of pollution versus somebody who works inside in a desk. Where do they live? Do they live in an environment where they don't have good access to HVAC systems? They don't have good areas of filtration, where they may be exposed, if they're living right next to a highway with their windows open all the time, to potentially have more exposure. So I think putting all those together is sort of a rough gestalt way to assess it. There are certainly biomarkers that we've started to think about from a scientific perspective that can look for that inflammation, the oxidative stress, and the injury that we talk about. So high sensitivity CRP, which is a marker of inflammation, can be variable, but that can suggest endothelial activation. It is nonspecific, so we have to be careful because it's not necessarily linked to air pollution. There's also some endothelial adhesive markers that can be upregulated. These are mostly experimental at this time. We can look at markers like BNP or proBNP or troponins in patients with congestive heart failure because sometimes exposure to air pollution can also bump those markers of injury and atrial stretch, but again, non-specific. It can happen for other reasons related to the heart failure itself. And then we also look at something called DNA methylation. So our DNA is our hardware. The way that we turn it on is our software, and air pollution influences what's called epigenetics, how our DNA gets methylated or changed. That's an experimental marker as well. So it's a long-winded way of saying, basically just try your best to figure out how much air pollution they're exposed to based on where they live, where they work, and who they are. But it's not really validated yet to have these risk prediction tools. So this is where I think we need to do better. Our health system, our physicians, we need to step up to the challenge. And I think what we need to do is systematically assess and educate at every visit. But I also think there needs to be a lot of public health messaging that comes from the federal government, from others, including the CDC, that makes people aware of the risks of air pollution. I know in some developing countries, in India, where a lot of my family is, there are messages like that. They tell people to stay home when it's really bad quality outside. But here in the United States, I don't think there's a systematic public health campaign that's out there. So I would encourage you to talk to your local hospital and see if you can launch something in your community to try to educate people, but at the very least doing it in the exam room, making sure that no cardiovascular patient leaves your office without knowing that exposure to air pollution increases risks of MI, strokes, atrial fibrillation, congestive heart failure, dementia, and can even affect your longevity, because that's something we don't consciously think about. I do encourage most of my patients to check the AQI, the air quality index, every single day when they decide what they're going to do that day, when they decide how much time they're going to spend outside. Certainly exercising, which we encourage our heart patients to do when the AQI is really bad, is a terrible idea, because then you're increasing your exposure, your dose to the air pollution. So I think educating patients in the exam room and outside the exam room through public health campaigns is really what needs to happen. The WHO has tried to do it. The American Heart Association has also tried to put this in as a modifiable cardiovascular risk factor. The Lancet Commission on Non-Communicable Diseases has put this in as well, but I still think the guidelines need to catch up. So I am really excited about this concept because I do think that this is a great way, an actionable way today, that we could actually translate some of what we tell our patients into action. So wearable devices, as you know, can monitor all kinds of things, from your oxygen to your heart rate, to your body temperature, to your heart rate variability, to even things like the impedance in your skin, which tells us what your fluid status is. So in my mind, if I had a genie in a bottle, I would wish for a wearable device that integrates the air quality index data, that alerts me and tells me when the AQI is bad outside or when I need to limit my time outdoors, and sends me sort of alerts about air pollution. because it assesses it independently. And then it starts to give me feedback as to how my body is reacting to the air pollution. So I'm thinking either people who work outside or are older patients or, what have you, people that are exposed to more air pollution, wear these monitors that tell them, okay, your heart rate variability is blunted. That means you may be getting exposed to more particulate matter 2.5, or your body temperature has gone up. That means you may be starting to launch an inflammatory response because I detect more pollution in the air, or your oxygen level has gone down, which means it may be affecting your lungs. So this is what I'm hoping for in the future, where wearable devices can help sort of bridge the gap between the clinician's knowledge, the patient's knowledge, and their day-to-day activity patterns to give them sort of real-time feedback into what they need to do. And this is akin to sort of a continuous glucose monitor. I use that in my patients all the time. And a lot of my patients that are pre-diabetic, they put the sticker on their arm. It tells them on an app on their phone what their sugar is. Now they know exactly what behaviors are causing that sugar to spike and what types of foods. So same kind of thing, I'm hoping can have a future when it comes to thinking about how to modify our risk of cardiovascular disease from air pollution. So I think a lot of things need to happen. First of all, the guidelines need to put their nickel down and say definitively, because there is so much evidence that cardiovascular disease is caused by air pollution, that it's a modifiable risk factor. I don't think that comes across loud and clear enough in the guidelines. So that's number one. Number two, they need to help us find risk stratification tools and incorporate those tools so that we really can start using this at the bedside. We really have a calculator or something else that we can use that's quick and easy, clinically validated model that tells us who might be at higher risk for air pollution, who we need to advise more, and whose risk we need to modify. So that's the second thing. The third, they really need to identify which high-risk patient populations might have the most risk from air pollution. Because again, here we're sort of left guessing. We don't really know what we're supposed to do, what we're supposed to look for. And then fourth, if there are biomarkers or other things that we could assay as clinicians to even potentially follow exposure to air pollution over time, or help people to sort of titrate their degree of air pollution, that would be incredibly helpful. So I think the guidelines have a long ways to go. I do think more of a focus on research about air pollution and cardiovascular risk would also help inform and fill in some of these gaps, because without having the research, it's hard to know which biomarkers are validated. It's hard to come up with a clinical prediction score, and it's hard really to know how to then modify the risk. So I think a lot of work needs to be done in this field, and I'm just really glad we're having this conversation, because it is something we're all exposed to, every single one of us, and it's something that can lead to heart disease in anyone.